Just for your information, you've probably had the American accent saying that we're recording the AGM and for posterity, and with all our public-facing meetings, they do eventually go on a public accessible link from the CCG website. So what I'll do initially is I'll go around everybody that I've got on my list and ask them to introduce themselves. So it's not necessarily in the order that you're appearing on the screen for each other. And so I've got myself, and then I've got the T's CCG as the host. So Claire Atty, if you introduce yourself. Yep, please.
Hello, I'm Claire Atty. I'm one of the corporate secretaries, and I'm minuting the AGM today.
Okay, thanks. Jake Graham.
Hello everyone, I'm Jake and I'm the Communications and Engagement Officer for Tees Valley CCG.
There's the boardroom for the CCG, which has got a number of people present, but I'll ask them to introduce themselves individually in a minute. Ahmed Fuat.
Hi, I'm a GP and GPSI in cardiology in Darlington.
Okay, Dave Gallagher.
Morning everybody, I'm Dave Gallagher, I'm the Chief Officer for the CCG.
Mark.
Morning, I'm Mark Pickering, Chief Finance Officer for the CCG.
Jean Golightly. Jean, you're on mute. Oh, well, Jean is our governing body nurse.
Sorry, Pos, I couldn't get off mute. Good morning, everybody. I'm the Executive Director of Nursing and Quality for the CCG.
Right. Craig Blair.
Morning, everybody. Craig Blair, Director of Commissioning for In-Hospital Services.
Hey, Caroline Gitcham.
Hi, morning, everybody. I'm Caroline Gitcham. I'm a lay member on the governing body of the CCG.
Richard McMahon. Now, I did have a note from Richard that, oh no, yeah, managed to get the microphone off.
Hello everyone, I'm the North East Lived Experience Champion for the Lens Network, and I'm also liaising with Health Watch on their community board. And my camera's not working, unfortunately.
Yeah, thanks. Diane Murphy.
Morning, I'm Diane Murphy, Director of Strategy and Delivery for Continuing Healthcare for the CCG.
Karen Hawkins.
Morning, I'm Karen Hawkins, Director of Commissioning for Primary and Community Care in the CCG.
David Emerton.
Good morning, everyone. I'm the Secondary Care Doctor on the governing body, which is a non-executive role.
Alex Sinclair.
Morning, everyone. Alex Sinclair, Director of Commissioning for Children, Young People and Maternity for the CCG.
Andy.
Hey, everyone. I'm Andy Mackay. I'm the independent member for the CCG.
Jake Graham. Oh no, we've had you already. Sorry, apologies. You've moved around on the screen. Karen Dales.
Morning, Karen Dales. I'm a lay member and Audit Committee Chair.
Janet Walker.
Hi, I'm Janet Walker. I'm Medical Director of the CCG. Morning.
iPad.
Morning.
Morning.
Sorry about that. I don't know how to change it. But anyway, I'm Kath Wall, a member of the Darlington Community Council, which is deals with CCG projects, hopefully, as we move on after COVID. Right. Been in the Community Council since its inception.
Welcome. Michelle
Thank
Thompson.
You.
Hi.
Hi everyone, I'm Michelle Thompson and I'm the lay member for Patient and Public Involvement for the CCG.
Eddie Uccelli.
Hi, I'm Eddie Uccelli. I'm a GP in the Heather Medical Center.
James Nevison. Don't know if, James is a non-executive GP in Darlington. He seems to be having problems with his microphone and camera. So he's a GP representative on the governing body. Ahmed Fuad. Oh, I've done your as well. John Howe.
There we are. Hi, I'm John Howard, GP in Hartlepool.
Okay, thanks. Mike Briley.
Morning, Mike Briley, Director Lead for Mental Health and Learning Disability for Tees Valley CCG.
Jessica Hollingsworth.
Hi there, I'm Jess Hollingsworth. I'm a GP in Middlesbrough. I'm one of the non-executives, and I apologise for my strange background. I'm trying my best to filter it out.
A fantastic blue screen as opposed to green screen. Simon Mason.
Good morning, I'm Simon Mason. I'm the clinical partner for Foundations in Middlesbrough.
Hi. And Malcolm Gittins. Hi. Hi, Malcolm.
Hi there, how are you?
Hi. Hi. If you just introduce yourself and where you are.
Yep. Hi, Malcolm Gittins, partner at Kingsway Medical Centre in Billingham.
Greetings, Malcolm. Right, and last of all, I'm Bolesław Posmick, salaried GP from time to time in Herworth and in Hartlepool, and clinical chair of the clinical commissioning group. So, I've got apologies for absence from Dr. Nick Timlin, partner in a practice in Hartlepool, and welcome all. It's very nice to see you all. It's actually sort of probably made it easier to attend a meeting by the fact that we're doing it on Zoom this time rather than physically in everybody's presence. So nice to see you all at our annual general meeting when we'll be presenting the annual report for your information and a review of the year. I'll just make a couple of comments to begin with. This has probably been the most unusual year for practices, particularly, and for patients and public that I certainly can remember in my clinical career. And particularly for the year that we're sort of going to be doing the report for, we basically had COVID hitting us, couple of peaks, and things beginning to settle towards the summer. Obviously, we're having another wave at the moment, but that doesn't quite come into the period covered by our annual report. But really, I got to take this opportunity to thank our member practices for the way they changed their ways of working to cope with COVID and keep going with what they could in relation to ongoing usual general practice care. They stayed open, they did everything that they possibly could, while at the same time coping with the starting of the COVID vaccination process, and particularly dealing with making sure that the most vulnerable part of our population was vaccinated as effectively as possible, and particularly taking note of the fact that the initial vaccination program was then changed halfway through in relation to the delays between the first and second doses, in order to make sure we got as many first doses into as many of our really highly vulnerable patients as possible. And, you know, for every probably 15 to 20 very, very vulnerable patients that the practices particularly managed to vaccinate, they probably saved a life. So noting all of the work that our member practices have carried out and the difficulties that they've been working under. But particularly since we needed to start a little bit later to allow people time to log in, I won't carry on very much longer, and I'll pass on to our Chief Officer and the directors within the CCG to go ahead with the annual report. Over to you, Dave.
Okay, thank you, Paz. We're just going to put some slides that we'll talk to. So great to see so many people on the call this morning. We're going to just share with you some of the experiences from last year. I always think it's odd doing an AGM because while we're sat here in July, almost in August, we're looking back way beyond 12 months ago. But this is very much focusing on the last year, 2020-21. So as we just, here we go. That's great. So if we can go to the next slide, please, Jake. So what myself and the directors are going to do is just take us through our areas of responsibility and just share some of the information that's in the annual report that's available on the website. As well as being an odd year, a challenging year, it's also the first year of the CCG is the newly configured Tees Valley Clinical Commissioning Group. So that's something else to bear in mind. This is the first AGM. I think Pos has alluded to it. There have been some huge challenges throughout the year. One of the first things I did when I came to post was send everybody home to work, and we'll reflect on how well everybody's risen to that challenge. But we've worked really hard as a team with all of our provider colleagues to make sure we've continued services amidst the pandemic. And as I said at the start, while that continues, and sadly we're still into waves of pandemic at the moment, we're very much going to focus on the last financial year. So I'm going to hand over to Mark to start us off looking at the financial performance for last year.
Thank you. You'll see on the screen there some of our key financial challenges for the year. Their successful results for 2021, which in the scope of COVID and a changed financial regime is a great performance. What we show on the screen there are 4 key tests. One is to do with keeping expenditure within our allocation, and we achieved that. We achieved a small surplus of around 0.3% of our turnover, so very close to breaking. We also have a key target that relates to our running costs. So that is the cost that we spend on running our organisation. We actually underspent or delivered surplus against that, which meant that money helped towards some of our programme or healthcare costs. Had we had a capital spending limit allocated to us, we would have captured that within here, and we didn't actually need to spend any capital in our first year of the CCG. So we've marked that one as not applicable. And our cash limit is closely controlled in terms of the amount we draw down from the Treasury on a monthly basis. So that was captured there, and we managed that within the resources too. Next slide, please. This chart captures how we've then spent our resources. So around about 1.2 billion, 1.3 billion. The main element on the right, the blue one, relates to our acute spend, so that's spend in our hospitals. The red one towards the bottom is spend in community healthcare, so district nurses, some of our community physiotherapy will be included in there. The purple one towards the left is a chunk on mental health spend, so that captures spend with our mental health provider, but also specific packages of care for those patients with mental health or LD needs. The large orange section towards the top relates to primary care. So that's costs of our GP services, but also costs of prescribing in there too. And then the tiny sliver at the top, the grey one, is the running costs of the organisation, which I've already mentioned. So just around 1% of the turnover.
Sorry, Mark.
Yes.
Sorry, could you get closer to the mic or move the mic closer to you? Because you started off pretty well, but you're getting quieter as time goes on. Thanks.
Okay. Yes, I'll do that. Well, at that point, Pos, I can hand over to Janet.
Right. Can I just take the opportunity to, what I'll do is I'll ask for any questions and comments relating to the section that's just been done in between presenters. So just before you carry on, has anybody got any questions or comments about our resources and distribution and shares of resources thus far? Because I'll also give everybody an opportunity to ask questions right at the end as well. But if there's any pressing ones just now? No? Okie dokie. Right, if you just move on then. Okay, thanks.
Hi, thanks, Pos. I hope you can hear me. If you can't, shout up and I'll speak a bit louder. As you've mentioned already, an awful lot happened in the year with regard to COVID, and it's how you summarise the past year and our COVID response in one slide. However, this has given it a right good go, and certainly it was a time where system working had a chance to come to the fore, and there was a really important role for the CCG to help working with our partners across health and social care to coordinate how things continue to run amidst the COVID pandemic. As Pos has mentioned already, there was significant changes in general practice, and there was certainly a role for the CCG to work with our general practices to support them to adapt and adopt the new ways of working and all the changes that impact on patients across the health and social care system across the Tees Valley. With our Tees Valley patch, understandably there was a need for us to link in very closely with the larger ICS region, and there's a significant need for mutual aid and sharing of resources, information, ideas to help us have the best response amidst COVID. As Pastor mentioned already, the COVID vaccination programme started in December, and yes, whilst that continues to go on now as we speak, and we have mobile vehicles today in Darlington, as well as mobile vehicles in Redcar administering vaccine today, as it's understandably a programme that has many twists and turns, with a desire for us to get as many patients vaccinated against COVID with their first dose and their second dose as we were able to do so. One element that obviously is very close to my heart is the COVID-19 oximetry at home programme. That was a way of us monitoring and supporting our patients with COVID to manage with their own condition as far as they were able to in their own home safely. But if any changes were detected of deterioration in their conditions, we could pick those up more smoothly and enable them to receive inpatient care more quickly to have a better outcome. And I'm delighted to say we have been shortlisted for a Patient Safety Award with that, and the team are presenting that tomorrow. A lot of our staff within the CCG who have clinical qualifications were able to be redeployed into frontline working, and obviously that included our clinical leads and our executive GPs, who obviously had a significant role contributing more at the coalface. Across the CCG, we have moved to remote. We did during the year remove. Let me get my teeth in. We did work remotely and obviously recognised that we needed to maintain business continuity. So it was a quick rearrangement, as many of you out there will also have had to experience as well. And yes, that was a very smooth process with our support from our digital colleagues enabling us to work differently at home. So a rapid year, Cos, and I hope some of that's done justice to it.
Thanks, Janet. Once again, a quick opportunity for any questions or comments at the moment. Certainly, the CCG made a point of redeploying as many of the clinical staff who were doing stuff in the CCG land into patient contact roles as much as possible. But also it was important to maintain a CCG business, because there was inevitably an awful lot of information and support needed to be provided to our clinical colleagues out in primary care, because of the radically changed working environment and the changes in the ways of delivery of finances, and the changes in expectations of what practices were needing to do and allowed to change their ways of working in relation to their existing contacts. So I think the CCG did a great job supporting the practices, and certainly practices did a great job supporting their patient populations. Okay, moving on to the next presenter, please.
Thanks, Boz. So I'll briefly talk through the performance position for the last year. I've got a couple of slides that will highlight some of the key performance areas. I think it's worth starting with a little bit of context. So obviously the NHS as a whole was significantly impacted by the pandemic. And in response to that, there was a need to step down all non-urgent routine services for a significant proportion of the year, which did lead to significant backlogs in waiting times for access to some of those services. We also had large capacity constraints placed on a number of the hospital-based services as well, due to infection control and social distancing measures that needed to be implemented, and we needed to divert significant resources to the pandemic response. So moving things from planned care to urgent care services. But I can report that we've implemented a number of recovery plans throughout the second half of last year and into this year in response to that. If we could move on to the next slide, please. So I'll start by touching on some of the planned care performance. Referral to treatment, that's the length of time that patients wait for elective care or planned care interventions. Last year, at the end of the year, we had around 3,500 patients that waited longer than 52 weeks for treatment. That's significantly higher than we would normally anticipate. And as a rate, just to give you a feel for how that stacks up nationally, in the Tees Valley, around 481 patients per 100,000 waited in excess, or would have waited in excess of 52 weeks at the end of the year. That's in comparison to a national position of around 723. So whilst we did have a significant number of long waiters, the position was considerably better than the national average. To ensure that no patients who'd waited over 52 weeks came to any harm, harm reviews were undertaken by all of our providers, and the CCG supported with that process. We also worked to ensure that any patients who chose not to access treatment because of concerns that they had about coming into hospital during the pandemic were also risk assessed to make sure that there would be no undue harm caused by continuing to wait longer. Alongside the RTT referral to treatment waiting times, we've got a target around diagnostics, and no more than 1% of patients waiting for access to a diagnostic test should wait more than 6 weeks. Again, during the early part of the pandemic, we did need to stand down a number of those routine, non-urgent diagnostic procedures, and that did lead to a significant backlog, which peaked at around 58% of patients waiting over 6 weeks at the height of the pandemic. As we've moved through the year, we've been able to recover that position down to around 8.9% at the end of March, which is a significant improvement, but still some way to go. And again, that compares favourably to the England average. If we could move on to the next slide, please. Just in terms of cancer, cancer remained one of our top priorities throughout the year, even while we were managing with urgent care pressures around the pandemic and ensuring that we had hospital capacity to deal with those who required an admission. In response to this, we have been able to maintain our performance against a number of the standards for significant periods of the year, with some performance required at year end. In order to do this, we've worked collaboratively with the hospital trusts and made use of all of the surgical capacity in the Tees Valley, operating a surgical cell, enabling patients to move around to different facilities to access the treatment and the surgeries that they require in the most timely way possible. We also were able to support a couple of our trusts implementing rapid diagnostic services, which again help reduce waiting times and access to treatment. So although it was a challenging year, we were still able to achieve some positives. Can we move on to the next one, please, Glenn? Thank you. Urgent and emergency care, a really challenging area throughout the year. The ambulance service has been hit by a number of pressures, increased demand, pressures around staff being available to man ambulance crews and provide responses, but also additional downtime related to the need to deep clean ambulance vehicles and to ensure that we're compliant with IPC requirements, infection prevention control requirements, that is. Those additional cleaning and IPC requirements reduce impact the ambulance service significantly. So around 85 hours per day of vehicles being out on the road, ambulances being available to respond, have been lost due to the need to actually clean the vehicles and turn them around. That said, we have managed to continue to deliver against the Category 1 standards, which are the responses to the most urgent need in our population. So that's a real positive. There has been some significant deterioration in the Category 2 responses, and that's been expected and is in line with ambulance trust providers across the country. In terms of the A&E standard, again, significant impact based on the need for social distancing, access to A&E waiting rooms, and the amount of space available within the departments to treat patients. What we've also seen is that the number of people attending with higher levels of acuity, i.e. people being poorlier, has increased when they've attended the department. That said, all of our departments have done absolutely everything they can to maintain the 4-hour standard. And you'll see from the graphic that North Tees and Hartlepool aren't actually participating in reporting against the 4-hour standard at the moment, because they have been piloting some new metrics around A&E weights. If we could move on to the next slide, please. Next slide basically summarises some of the work that we've undertaken around in-hospital services, and throughout the year we've continued to work on the Tees clinical services strategy in the background, which is a programme of work to ensure that we improve outcomes for patients and strengthen the stability of the services that are currently in place. In addition to that, there's a number of programmes that we've also looked to support our acute colleagues with, and they include NHS 111 First, Prep Well and Cancer. Just a little bit about each of those. NHS 111 First was an initiative that was implemented, piloted across the North East and then rolled out nationally, aimed at ensuring that urgent emergency care could be provided to patients via the NHS 111 telephone support line, reducing the need for individuals to either attend an A&E department or contact their practice. And that's now been rolled out nationally right across the country. Prep Well, recognising that we've got a number of patients waiting longer than they otherwise would have. Prep Well is an initiative to make sure that patients are ready, fit and healthy for surgery, to ensure that they get the best outcomes possible and recover from their surgery as quickly as possible. That has led to us being awarded a runner-up in the British Medical Journal Awards, which is a real positive for the CCG and the Tees Valley system. And then in terms of cancer, I've already touched on some of the work that's been undertaken around cancer and the introduction of the rapid diagnostics and the cancer surgical cell. There was also a number of initiatives that have been rolled out this year to try and promote signs and symptoms and awareness of cancer and make sure that patients still come forward, even though it's been a really difficult, challenging year and access to services has been impacted. So we've had the Why Wait Cancer Doesn't awareness campaign and the Do It For Yourself, which is in relation to lung cancer and persistent coughs. So they're both some real positive campaigns that have been taken forward in year. And I think, that's it from an in-hospital and performance perspective.
Thanks, Craig. So once again, anybody want to make any comments or queries or observations? Craig, can you just go back to the people waiting, your first slide, I think. Just a quick question. Yeah, sorry, forward one slide. Yeah. So just for context for people attending the meeting, there were 3,400 odd patients waiting longer than 52 weeks. How many would we normally expect in a year for our CCG area? Broad brush figure.
Yeah, broad brush, no more than a dozen or so patients waiting on 52 weeks. Because the Tees Valley CCG and the former CCGs within the Tees Valley would have required very few 52-week waiters. So we've always been really good in terms of delivery of the waiting time standards, driving towards delivering that maximum wait of 18 weeks wherever possible. So that this is a significant challenge for us as a system and our providers as well. But what we have been able to do is work very collaboratively across the Tees Valley, all of the NHS providers, and make use of the independent sector as well. So we're fortunate that there are a number of independent sector hospital providers on the patch, and we've been able to use their capacity to ensure that waiting times benefit from that. So we've been able to transfer patients over to their facilities and make sure that they're treated in the most timely manner possible. What we have been able to do is look at prioritising those with greatest clinical need, so that those individuals are treated first. It has meant that some individuals have waited longer than we would have otherwise liked, but some significant work's underway in this year to try and address those waiting times, and we've already seen some significant reductions in the number of over 52 weeks at all of our hospital providers.
Yeah, and for assurance for others as well, patients waiting, the harm reviews isn't just a one-off per year, it's an ongoing process where there is a reassessment in relation to potential harm if people are waiting increasing lengths of time.
Absolutely, because yes, that's an ongoing process. As patients continue to wait, their case will be reviewed, and any further diagnostics or any additional information that's available will be considered to ensure that no harm is caused to that individual.
Okay, thanks. I haven't had any other sort of hands raised or anything, so if we move on to the next person, please.
Thanks, Pos. I'll cover the primary and community care area and some key highlights. Obviously, there's lots of information within the annual report itself, and some of my colleagues have already alluded to a number of the key highlights for primary care during 2021. However, it needs to be said that it can't be underestimated the tremendous efforts that both primary and community care through our trust services have made during 2021, and in particular in the height of a pandemic. Our services continue to develop and support patients. They continue to support staff, whilst also moving forward areas of transformation during this period. A couple of the areas in terms of the slide, the primary care network development. So primary care networks are groups of practices working together. They haven't only continued to deliver the services that they were contracted to provide, for example, extended hours during the period of the pandemic and enhanced health in care homes. They've also developed their networks through recruitment of additional workforce and collaboration across partner organisations. So networks had the ability to recruit to a number of roles during 2021. That didn't stand still during the pandemic.
Sorry, Karen. Apologies, folks. There's a little tiny dog barking in the background. I suspect it's the one that was barking yesterday outside the CCG. Is there any way you can close the window that faces the dog at all?
We'll not shoot the dog, we'll just close the window.
I'll try
It's a huge Great Dane, actually, cause. Is that better?
I'll try
yeah,
and
it's a bit quieter. Yeah. If you move the mic a bit closer, Karen.
It's on the ceiling, so I would try, but I'm only 5.
Oh, sorry.
So,
Right.
so I'll try and speak a bit louder. Hopefully that will drown out the noise of the barking in the background. I think they're just supporting some of the comments that we have in relation to the hard work that's been undertaken. So networks had the ability to recruit to a number of roles during 2021. And they have done that. They've not stood still. They've included in the first year recruiting to clinical pharmacists, social prescribing link workers, and also first contact physios. They've worked collaboratively with wider partners in the trust to make sure that we look at the workforce as a whole. And across the 14 networks that we have, they recruited 91.25 full-time equivalents. So in essence, 107 extra additional staff members within primary care across our networks, of which we have 14. And to date, they've even continued to employ further in terms of varying roles to include now care coordinators, importantly, mental health practitioners, and making sure that there is a multidisciplinary approach to making and working together across both primary and community care. These additional staff obviously support the sustainability of general practice and the workforce going forwards. Most importantly, the primary care networks, bearing in mind they were 9 months old at the start of the pandemic, and 9 months old of working together as groups of practices, they've absolutely phenomenally delivered the COVID vaccination programme, which started, as Janet said, in December of last year. The workforce, again, working collaboratively with other partners, working with our social care partners, working across practices, working with our trusts and our federations, have ensured that the population of our area were offered the vaccine, and they've coordinated their efforts to deliver the programme successfully. And as Janet said, it's not stood still, it continues today, and we'll work through that through the rest of this year with the primary care networks to make sure that the booster programme is continued to be delivered. Most importantly, last year, it was really important to ensure that we had access to services for our patients. And during 2021, it was really important that we managed that, and we were able to not only support our patients, but the workforce within primary and community care. And a number of schemes that we've outlined were introduced to support access. So we put things in place like the COVID hot clinics. That was not only to manage demand, but to ensure that the majority of patients that were either suspected of having COVID were managed in a standalone practice, reducing the risk to others, and also ensuring infection prevention control measures were easily adhered to. And that was developed in each locality and supported very well, not only by our practices, but by our federations in each of our localities. Janet's already advised of the success of the COVID oximetry at home to support patients in their own home, patients making sure that they receive care and support in the comfort of their own home, and being loaned an easy to use device of a pulse oximeter to ensure that they were able to be monitored at home, and local doctors and nurses were monitoring those patient readings and advising if further support was required. That was supporting access to both general practice, but also supporting our wider system response in terms of trying to ensure that where patients could be managed safely at home, that they were. I think one of the key areas as well in terms of access is the digital developments. The digital vision for primary care was already underway before the pandemic, but to support better access to general practice at the height of the pandemic, it was really important that we drove that forward at pace. And the introduction of e-consultation, video consultation were introduced, and our digital programme was realised within this year. Although telephone contact did remain in place for those that either did not wish to or did not have the ability to use digital technology, to ensure that they still had access to general practices, whilst nationally general practice were advised to introduce a triage first model. In relation to community services, again, importantly, access was really important. There was a development through the teams working with our partners to introduce the rapid eye care service to make sure that people with urgent eye concerns and were able to access services. There was the digital access to the local healthier diabetes prevention programme. So prevention was still focused on during this period. And then also importantly supporting patient choice and making sure that we were working as a system to introduce the care home capacity tracker, making sure that we were able to identify where there was information for our care homes as we rolled out the Enhanced Health and Care Home project, working with primary care, that there was access across both health and social care to help reduce the time taken to discharge people from hospital, to make sure that they were placed into a home of their choice and also supporting their discharges. So a phenomenal effort across both primary and community care during 2021, and that has continued today. Thank you, Pos.
Thanks, Karen. Any questions or comments? I think the little dog in the background was supporting the fact that it could have been a rough year, but primary care really did pull out the stops to make sure that things were delivered as far as possible, and also to make sure that while caring for patients who potentially had COVID, they actually also took what precautions were needed to maintain their clinical safety in order to keep on delivering services in the future, but that they also definitely were open right the way through, and they saw patients face to face as and when it was deemed necessary. Okay, so who's next? Who is going to be next?
Alex.
Alex. If the little dog gets very noisy again, would you try using your microphone rather than the boardroom one? Thanks.
Yeah, okay, I will, thanks. Thanks, Pos. So in terms of children, young people and maternity services, some highlights. We worked with County Durham CCG to produce a resource called the Little Orange Book, and that's a resource to support parents of babies and small children when they're poorly. It uses a traffic light system to help parents and carers decide what action to take when their child's sick. Another project which has been ongoing for some time is the neurodevelopmental pathway in Hartlepool and Stockton and Darlington. We've implemented this in conjunction with TUV, parent carer forums and the local authorities, and that's to improve the autism pathway for children and young people. It's a needs-led approach, the neuro approach, and families are able to access support and need from both health, education and the local authority while they're on the diagnostic pathway. And we're working with the parent carer forums in Middlesbrough, Redcar and Cleveland to implement that by September 2021. In terms of vulnerable children during the pandemic, the team led to work to identify and support the most vulnerable children and young people. We worked with our 5 local authorities, and in particular our designated clinical officers played a major role in this, and we worked to identify the support required from health, education and the local authority to ensure that children and young people who were vulnerable got the support they needed despite the school closures and the lockdown. We also implemented a virtual programme to help parents and carers understand and respond to their crying baby. We continue to work with all 5 local authorities around the SEND agenda, and in particular in the Hartlepool area, the Department of Education found that we had made clear and sustainable progress, so monitoring was no longer required in the Hartlepool area.
Sorry, Alex, for the benefit of particularly the lay members attending, SEND stands for?
Special Education Needs and Disabilities. Thank you, sorry about that. So the key to our success in all of our programmes is our strong partnerships and with our local authorities and trusts, but in particular with our parent care forums and maternity voice partnerships. We've got very close relationships with all 5 parent care forums, and they've worked with us to co-produce materials and services for special educational needs, and also our new developmental pathway. The CCG worked very closely with the maternity voice partnerships, and during the pandemic we had regular meetings with them to ensure that we updated on the necessary changes that were made to maternity services during the pandemic, And we also created joint messages to ensure that people were reassured during the pandemic, as well as developing leaflets to dispel any myths relating to pregnancy and COVID. Thank you.
Thank you very much. Any comments or questions? It was particularly important that with children being, during the lockdown periods, being at home and less contact with school in some cases, it was clearly crucial to make sure that vulnerable children's lists were effective and delivered the protection that children needed. Okay, so I don't see any hands or anybody else wanting to raise any questions or queries. Okay, so is it over to you, Mike, for the mental health?
Thanks, Paul. Apologies for my non-corporate background about IT issues. As with all other services, huge COVID impact on our range of mental health services and learning disability services. But as predicted, the lag of the impact of COVID is now starting to hit as complexity of presentation is becoming prominent, and presentation of people who previously hadn't been known to mental health services as well. So the demand is increasing. So in terms of literally day one of kind of lockdown and COVID, we launched a newly procured service for our improving access to psychological therapies, which is the Impact Service. So that's a primary care therapy service offering talking therapies, CBT, etc., and outreach services. So they obviously struggled with kind of access of people into that service because people weren't getting out and accessing services, but are now starting to recover that position and starting to improve and get full mobilisation of that service. Another key aspect across the kind of year, particularly COVID impact, was the delivery of learning disability annual health checks, and another Herculean effort by primary care to not only hit the targets, but to surpass them by quite a way. And again, that, you know, it was critical that we did that for this complex bunch of patients that we've got and individuals that we have. And they stepped up and did a fantastic job with that. One area that we did manage to continue with was the CAMS transformation was important as children were off school.
Mike, sorry, CAMS for the benefit of our...
Oh yeah, child and adolescent mental health services. Thanks. Beg your pardon, pause. It was important that we continued with that work that had already started with children being off school and needing the support, and often school can be help, and it's the issues are at home more than at school and vice versa. So it was important that we provided support during the pandemic and continued with that transformation based on the Thrive model, which is around getting help, getting more help, and then through to more specialist support around providing that holistic support to not only the children, but to parents and carers as well. General bed pressures continue to increase over the year and are probably at a critical point now across both mental health and learning disability services. And as I mentioned, the increased acuity, complexity of presentation as an impact of COVID is hitting the system hugely. I think it's already been mentioned, we're working with primary care networks to look at aligned roles for mental health practitioners. Those have been agreed and will start to come into place this year. And equally, a big piece of work around aligning more services around primary care and social care and into the community is around the community mental health framework. A lot of work was done to secure funding, which will come into fruition this year, but the work was done throughout 2021. And then again, as part of the wider children's work, the rollout of mental health support teams in schools, and we've finally got the last piece of the jigsaw in place for South Tees with that. But again, that's another crucial role around getting that holistic support based on the Thrive model to where it's needed and getting that early help for our children and young people.
Okay. Thanks, Mike. Any questions or queries or points to be made in relation to mental health and learning disabilities, which is a crucial area to protect our patient population, and particularly really good that we did managed to do the significant numbers of learning disability health checks for our vulnerable patients. Okay, thanks. Is it over to you next, Jean?
Yeah, good morning, everybody. I will rattle through this because you've had the opportunity to see the slides and I'm conscious of the time. But as is the case for everybody, roles and responsibilities continued as usual, even though we were in very unusual circumstances. And many of the things that the quality and safeguarding team do are based in statute. So what we actually did was we flexed portfolios to make sure that we could continue to do that, but also feed into the wider system response collaboratively with a number of 8 partner agencies, but also providers of all different sorts. Karen's already provided great detail on the work done by primary care, so what I've focused on is additionality there. You can see the work that was around PPE, which I'm presuming now that that's in the lexicon of everyone, like you don't need me to spell that out, Pos. But you can see that things continued. I think just to give a special mention to the infection prevention control and the PPE work, because although we were doing it in relation to some of our very vulnerable populations, we worked with a lot of partners to make sure that they were also upskilled, because lots of people had to continue doing their job in different circumstances. So there was a lot of learning there around PPE. And then throughout that, just as you've heard from other colleagues along the way this morning, we've still continued with that push for improvement and system working and forward facing in terms of getting the strategic group for quality and patient safety. And this is where a number of us, it's no longer just a CCG approach concerns, but it's a wider membership and focus across the whole patch in terms of that. And I think that's really all I wanted to say, but happy to take any questions.
Thank you, Jean. Yes, I think this is one abbreviation I think everybody in the country knows by now, with PPE being personal protective equipment. Okay, so any other, anybody else for queries or comments? No? Okay, moving on.
That's over to me. Thank you, Pos.
Thanks.
So continuing healthcare, this, for those that don't know, is provision of healthcare for probably our most vulnerable patients in our community settings. And we have, you know, a fair few thousand of patients in our communities in receipt of some form of continuing healthcare. Because of COVID-19, the CHC assessments were suspended in line with the national directive. And once we did that, the CHC team rapidly reviewed their priorities, and a significant number of the CHC nurses were redeployed to support frontline COVID response, both in acute settings, but also to support CHUV in particular, when they were impacted by many staff going off with COVID.
Sorry, Diane, CHUV?
Tees Esconway Valley.
Thanks.
NHS Trust. They also supported care home infection prevention and control, and supported the assessment and distribution of personal protective equipment, particularly to the personal assistants who were employed for some of the continuing healthcare patients. For the staff that remained, we still needed to provide a service to the existing continuing healthcare patients, even though new patients' assessments were suspended. As a result of that, we set up a single point of contact for all of the existing patients, so they could have a key line of access to sort out queries and issues with care, of which there were many. And I think many of you who work with patients will appreciate that. Many services closed down, education settings, respite settings, which meant that families and informal carers were under immense pressure to continue to support patients, many of whom's needs escalated during this period. So, you know, those existing patients required more intervention. Karen already mentioned sort of discharge of patients, and the CHC team supported the new discharge to assess arrangements. Patients rapidly moved out of hospital, and they needed support from health and social care partners. The continuing healthcare team were part of that, and that continues now. That discharge to assess continues to be in place, and actually has been a very successful change. Additionally, we moved very swiftly to virtual assessments. That wasn't without its challenges, and again, many of you will recognise those challenges, but it was done nevertheless, and those challenges in time have been overcome. From September, the systems and processes were reinstated, so patients had to be assessed for continuing healthcare, and we had a backlog of over 2,000 patients who needed assessment. Those patients were had their assessments completed in line with expectations by the 31st of March. But I have to say that was with support. We can't do that on our own. And just to acknowledge the support that we had from social care colleagues with that. So we met the expectations of delivering that. And that's all from me.
Thanks, Diane. So once again, opportunity for questions or comments. Clearly crucial to make sure that our continuing healthcare continued to be delivered, and it's really great to have cleared up a backlog despite the challenging circumstances that everybody was working within in health and social care. Okay, so back to finance. Who is that? Back to you, Mark. Yep.
Yes, it is. Thank you. So the finance role is quite closely linked to control and governance, and you can imagine during a time of COVID where we had to make quick decisions and response very quickly and make some of those prompt payment mechanisms work. There was lots and lots of work required to change some of our systems, making sure the CCG stayed safe in its use of the public sector monies. And what we've captured on the slide here are a number of those roles that finance carried out in terms of drawing down the right amounts of money where they were made available at a national level, making sure that we put the systems in place to spend that appropriately and quickly where it needed to do so, and also determine that it was good value for money. I'll just go on to the next slide, Pos, before we stop, if that's all right. At the same time as putting all that control in place and producing the accounts, the wider team have also focused on some of the digital and estates work. So the digital consultation, e-consultation and video consultation that Karen mentioned earlier was a key task for us, as well as at the same time the rollout of Microsoft 365 software across all of our estate, whether that was within the CCG or across primary care. We mentioned about the role of primary care colleagues working remotely and the deployment of lots and lots of laptop equipment to enable that to happen, to keep our staff as flexible as possible. And in addition to that, the role of linking the care homes to enable us to work using email in a more effective way. And at the same time as COVID, the response from the estates team has been immense in terms of making sure that those sites were valid and available for use, working closely with colleagues in property services in particular. We've also picked up some of the work required for preparing primary care network estate strategies. That piece of work is ongoing into this financial year. And some of the day job doesn't stop, so there are still challenges, queries, problems in relation to all of our estate, including CCG and primary care, plus the work on new developments as and when they're required, and responding to all of the planning applications that continue to work their way through the system. So that really summarises some of the enabling function of finance, digital and estates along the way, Pos.
Thank you, Mark. And certainly the digital IT working really facilitated the delivery of the altered ways of working within primary care. And you can't avoid the fact that you still have to have the monies flowing smoothly in the background to facilitate smooth delivery to the patients that need the services. So, any questions specifically about the finances and infrastructure? No. I'm working on the assumption that that's it for the presentations. Is that correct? Yeah. So,
I think it's just two more slides to go. I'll be very quick with these, Pos. Probably just to reflect and first of all thank directors for presenting the work that they and their teams have been doing, but actually for doing the work as well through the year. I think it was a very challenging year, so a new organisation, COVID, and all of the stuff, the extra things that you've heard about today. All we've managed to do today is scratch the surface for this, but it's very much been a team effort. The screenshot on the slide there is some of the team celebrating last year the NHS birthday. But I think a year of huge progress that's been made, dealing with some really challenging issues in terms of the services, COVID, personal issues as well for the team and the staff and the practices. The key bit of the team effort has been, it's not just been a team effort of our team, it's been the team around Tees Valley practices, the hospitals, social services, the councils, and actually the public, because the public have really helped with this by adhering to some of the messaging and things. So big thank you on behalf of me and us to them. And probably just finish with one last slide that we're now into 2022, and moving in towards the world of integrated care and transitioning the organisation into a new system. Lots of work to be done on that, but lots of learning from COVID, especially some of the acceleration of some of the work like the digital and other bits and pieces that we will continue as we move into this year. But probably draw to a close there, Pos, and happy that any of us take any questions, recognising the time that we've got left.
Right, thanks, Dave. I've got a hand up from Ahmed Fuat, so over to you, Ahmed.
No, just thank you for all that, very interesting. Just to add that there has been other work going on, access that Karen mentioned. We've now got the digital weight loss program that has been launched, and obviously in my CVD role as a member of the clinical National Clinical Network, we've also launched a lot of programs like BP at Home, which is being piloted in various areas, including County Durham and parts of Tees Valley, Heart Failure at Home, which is being piloted in Darlington. And there's obviously diagnostic hubs and the cardiac networks being reformed to try and tackle some of the backlog. And can I just say that I think we should be putting on record that we've had 1,561 health and social care workers who've died of COVID, as well as over 150,000 of our patients. I think it's been a horrible time for them, their carers, and we should be putting that on record as a CCG.
Yes, certainly we'll be putting on record the comments in relation to the number of patients who've sadly died, and included in those patients have been our NHS staff colleagues who unfortunately in the process of providing care and just living their day-to-day lives have unfortunately succumbed to this very, very difficult condition to respond to very quickly. Anyway, thanks, Ahmed. opportunity, particularly for our public attendees and also any other practice representatives to put in any questions or comments. If you just speak up or raise a hand with the little sort of gesture reactions icon at the bottom of your screen. Caroline.
Hi, Pos. I think I just wanted to say that I think obviously we've been doing all of this stuff virtually over the last 12 months, and I think to see from the presentation the work that's been undertaken over the last 12 months and the way that the staff in particular at the CCG have pulled together and responded as quickly and as professionally as they have. I think it's been tremendous to see it come together, and I just want to put on record a thanks to the staff and the leadership at the CCG. I think it has been tremendous. So well done, folks. A very, very difficult year, but the way you've responded has been fantastic.
Absolutely, Caroline, I second that. So directors who are talking to us just now, if you could pass on the thanks of the governing body and the people at the annual meeting on to everybody that everybody in your teams. iPad, sorry, I've forgotten your name, I'm afraid. You had your hand up.
Athwal, yes. I reiterate and agree with every word that's just been said. I've thoroughly enjoyed the meeting and just well done to one and all.
Thank you very much. Absolutely. So I think on that note, especially since we're slightly overrunning, unless anybody has anything to add just now and put your hand up or speak, I will say again and reiterate thank you very much to one and all within the CCG, within primary care, within the wider health and social care system, and we absolutely note the toll that this that COVID has taken over the last year, but the sort of stupendous, remarkable efforts that everybody has made to deliver the health care for the population of the Tees Valley that we are here to do. And on that basis, I'll wrap up and say thank you very much for attending. And we've managed to sort of get away from the little weenie dog in the background.